We shall be continuing in our class of the female genital tract in R.A.T.S, Racing Against Time for students in pathology. Two topics I intend covering in today's class. One is a teratoma and another a dysgerminoma. Either of them can be essays, short notes, part of an essay, specimens in pathology, surgery, or even OG. Teratoma is a totipotential germ cell tumor with representations from all the three germ cell layers, namely the ectoderm, endoderm, and mesoderm. This definition you people shall retain. And regarding the sites of teratoma, you find that there is the ovary, testis, sacrococcygeal region, retroperitoneum, mediastinum, anywhere in the midline of the body, outer angle of the eye. See the number of sites where we can have a teratoma. So you should be fluent with all this because it is a common question in pathology as well as in OBG and surgery. In most cases, it is an incidental finding. It does not present with symptoms, but then in some case there can be a torsion. Therefore, it presents as a surgical emergency. Sometimes the teratoma can coexist with other germ cell tumors such as the mucinous histoadenoma. The types of teratoma can be as follows. Fundamentally, mature and immature. Mature teratoma more common in the ovaries where it is called a benign cystic teratoma. Immature more common in the testis and there will be a malignant component. It can also be classified as solid and cystic. Again, teratoma of the testis is solid, ovary is cystic. There are some specialized variants such as struma ovariae and carcinoid. Please remember these, this will fetch you marks. And finally, there is the malignancies arising in a teratoma. This includes a squamous cell carcinoma, an adenocarcinoma, malignant melanoma, rhabdomyosarcoma. All these malignant tumors can arise from a teratoma. So please have this in mind. This is a specimen that you people should be able to describe. Let us assume that it is a specimen. The tumor can vary from a few to several centimeters in diameter. The external surface is grayish white and smooth. If it is an ovary, it is identified by means of a fallopian tube. The outer surface is smooth and gray white, whereas the cut surface, it will be showing solid and cystic areas. Look at this particular specimen. It is a large cystic space and then there is a solid protuberance. I am also seeing some tufts of hair projecting into the cystic space. The cyst may be uniloculated or sometimes multiloculated. Again, a cut surface of the benign cystic teratoma, I find a solid nodule that is projecting into the cystic space. This is called the Rokitansky's protuberance or mammillary body or dermal nipple. All are the same. Rokitansky's protuberance or a mammillary body or a dermal nipple. The importance of this particular region is it can contain an embedded tooth or fragments of bone, etc., to make the diagnosis confirmed. So large cystic area and then Rokitansky's protuberance. And in any of this teratoma, we will have to look for the tufts of hair. So this is a multiloculated teratoma in which there are cystic spaces filled with pasty, sebaceous material. And these are all wetted tufts of hair which can be seen within it. This is another specimen of a teratoma in which I am finding a tooth, maybe another tooth or a fragment of a bone, a large cystic space which is showing jelly-like material, and this is a thin cyst wall. Please also observe the strands of hair which are traversing the cystic space. So this is a short commercial break. What do I mean by it? And we are seeing this assorted biscuits. Assorted biscuits are these. So look at this one. There is a sweet biscuit, a cream biscuit, a chocolate biscuit, and then some sugar coated biscuits, etc. All are there in the same container. What relevance has it got to our discussion? In the microscopy of a teratoma, I find that there is an assorted pattern of tissue. There will be representations from the ectoderm, endoderm, and mesoderm. In this particular slide, I am finding the cartilage. There is a connective tissue, maybe collagen and smooth muscle, areas of sebaceous cells. There is sheets of fat, and then there is also a glandular epithelium. All of these can be seen. So I am finding the epithelium, the connective tissue, all this. So this is a list that I had seen in this particular one. And they have got absolutely no relationship to each other. Cartilage, suddenly I am seeing fat, suddenly I am finding the smooth muscle and the sebaceous glands. And this is a beautiful line diagram that I had picked up from the photos. And I would like you people to draw this diagram. So there are glandular spaces, and then there is some kind of a neural tissue. There are fat cells or adipocytes. Again, glandular element is over here, the supporting stromal connective tissue. And this is probably smooth muscle. So all of these are there. I would like you people to kindly draw this diagram in your record. Therefore, the teratoma, it is composed of representations from all the three layers. And we see tissues such as epithelium, connective tissue, bone, collagen, fat, lymphoreticular, neural, and they have got no relation to each other. Another microscopic picture for you to understand. So this is the stratified squamous epithelium, skin-like one, and there is the laminated keratin, the glandular tissue and cartilage, and supported by the connective tissue. This particular diagram also you can try drawing. There are some variants in a teratoma. One is a carcinoid. Carcinoid is an organoid tumor and it is not commonly seen. It is usually seen in the gastrointestinal system. And I find that there are some regular tissue which is more or less uniform. And the other is, obviously, these are all resembling the thyroid follicles, and this is called struma ovariae. These are the two special variants of teratoma. And finally, this is a testicular teratoma. When compared to the previous pictures, I find that this is solid. There are not many large cystic spaces. One or two are here, but it is predominantly solid. And when I look at it, it is composed of immature tissue. There will be the immature neuroepidermal tissue and the mesenchymal tissue. So this is called an immature teratoma, common in the testis. Yet another variant, Bailey and Love, the surgical textbook, describes it as a third leg. You find that there is a fetus and then it is sitting on a third leg, a sacrococcygeal teratoma. These are the basic differences between the ovarian and the testicular teratoma. In the ovary, it is cystic, testicular, it is solid. Mature, immature. Neural tissue is mature, primitive neural epithelium. This is benign, and in testicular teratoma, there are greater chances of malignant transformation. I think we'll go on to the next topic, dysgerminoma. This is also a repeatedly asked university question, usually a short note. It is a malignant germ cell tumor of the ovary. The common age is about 10 to 30 years, but it can occur beyond that, 40, 50 years also. 10% of the tumors are bilateral. And it is rare, it forms only 1% of the ovarian tumors. It is not functional in the sense there is no hormone production. The risk factors, there can be a gonadal dysgenesis which can lead on to this tumor. So this is a tumor over here. The ovarian outline is maintained. It is solid, and the cut surface, it appears myelobulated. Another picture. It is pear-shaped or ovoid, and then the ovarian outline is somewhat maintained, solid, grayish-white. It can measure several centimeters, and it is soft and fleshy. No prominent areas of necrosis or hemorrhage. This is a seminoma over here and a dysgerminoma. The dysgerminoma is described as a ovarian counterpart of a seminoma. This we shall be seeing later on, but I would like you to kindly appreciate the similarity between both. Both are ovoid, solid, and the outline is maintained. And this is one tumor and another. In both, I find that there are groups of large cells with large vesicular nuclei, a clear cytoplasm. And there are some septae. Here also I am seeing the septae which are filled with lymphocytes. This also, the description is fitting both. This is a seminoma, whereas this is a dysgerminoma of the ovary. Both are similar, and this particular diagram you people can draw in your record for seminoma. We had described this earlier. So large, lightly bosselated, solid, fleshy. And this is a dysgerminoma that is being removed at surgery. Please appreciate the external surface that is bosselated, smooth, somewhat brownish, shiny because of an intact capsule, but still it is malignant. And what happens is an ovarian artery, and sometimes there can be a torsion of the ovarian artery so that it presents as a surgical emergency. Another reason for presentation will be hypercalcemia. So this acts as a paraneoplastic syndrome. You people will have to mention this in your answers. A picture, I don't think it needs to be described. Here, in this one, I find that there are large clear cells with a central vesicular nucleus. So this is a tumor cell, and this is a septae, and that is having a few dark cells, namely the lymphocytes. Please draw this diagram it will fit both the seminoma and the dysgerminoma. It is large, round, pear-shaped, solid, homogeneous, no hemorrhage necrosis. The large green arrows in this point to the tumor cells, whereas the small yellow ones are the stroma with lymphocytes. So the microscopy, you people will have to explain uniform, moderately large cells which are polygonal, arranged in nests, vacuolated cytoplasm, large nucleus, some cells show nucleoli. And the tumor cell nests are separated by fibrous septae infiltrated with lymphocytes. So this is one. The same description, but the purpose of the slide is different. There are some tumors with similar histological appearance, and they are seminoma, dysgerminoma, and pinealoma. 3 tumors with similar or identical histological appearance. For the sake of completion, we shall go on to the spread of a dysgerminoma. It is usually to the regional lymph nodes and restricted to the pelvic organs or adjoining organs such as the colon. The treatment is chemotherapy and radiotherapy, and the prognosis in general is good. The marker for a dysgerminoma can be from the following panel. One is serum lactic dehydrogenase, 2 placental alkaline phosphatase, and 3 is CD117. Please doctors remember the panel of markers, it will fetch you marks. Gracias.